Morning, everyone. Welcome to the Neurologic Patient Assessment and Advanced Neurologic Tools. My name is Randall Faber. I'm one of the neurosurgical PAs with GNI.
I'm Danielle Brown, also one of the neurosurgical PAs with GNI.
I'm Ellie DiBernardo. I work in the Neuro ICU with these guys at Crozier.
So we wanted to welcome everyone to our talk. This will be an opportunity for us to go over really the basics of why this is important. It's sort of a fundamental sort of approach to when we take care of neurologic patients. We always really want to stress why the neurologic exam is important, right? I mean, it sort of sets the bar for how we're going to take care of these patients.
Yeah, we wanted to really stress, for us, this is the main way we know how our patients are doing. We use the physical exam to help guide us in making surgical decisions as well. And so being able to have colleagues and staff who are able to perform a proficient neurologic exam is key to everyone's success and to patient safety.
Definitely. I think we can't understate the importance of this, especially when we're taking care of patients in the hospital. You know, we can't be around our patients 24/7. And so we rely heavily on experienced providers, especially our nurse colleagues, to really be the #1 advocates for those patients and have a really good sense of what's going on. I mean, we can't understate the importance enough of how our ICU nurses really are the boots on the ground 24/7 to give sort of feedback on how patients are doing. I mean, wouldn't you agree, Ellie?
Oh, absolutely. Yeah, I'm in there constantly. You have a whole list of patients you have to see that you see once or twice throughout the day, but I'm in there every hour, at least sometimes the whole time. And so I'm going to see it first, not that you would miss it, just that I'm your eyes there. And so I'm able to call and let you know if something needs to happen.
Yeah, so what we wanted to sort of focus on, especially for this talk, is really about what are the need to knows when we talk about patients that are being evaluated from a neurologic condition. You know, this is fundamentally different than what you learn in a textbook for somebody who's doing a neurologic exam. It doesn't really help anyone to sort of go through sort of rote memorization of what you should be testing. It's really about what the patient's diagnosis is, how do we tailor their exam to their diagnosis, and really what is the clinical features of the exam that you should be really aware of when you're taking care of patients with that diagnosis. So that's what we're going to focus on mainly during this talk.
Yeah, we want to guide you on how to perform a thorough but quick exam. As we said, the nurses are going in there numerous times a day. You're much more likely to pick up a subtle change much faster than a provider because you're there more. And so we want you to be able to go in 30 seconds or 60 seconds, perform an exam and be able to call and say, the strength went from a 5 to a 3. I need someone here now. Yeah. And so that's what we're going to cover today.
Awesome. So what we wanted to start with, obviously, if we have any questions, we can answer them as we go along. This will be a very interactive opportunity. We want to tailor this to folks that may not necessarily work every day in a neurologic setting. You know, as let's say you're a nurse or a provider on the floor who potentially takes care of medical patients, general medical floor, maybe you're on a cardiac floor. You know, what's a good neurologic assessment to have in your back pocket? So that's sort of what our focus will be. And obviously tailoring to our stroke scales and to opportunity to go over some clinical cases. Mm-hmm. So for us to start, we're just going to sort of go through and sort of delineate some aspects of the acute neurologic exam that we think are the most important. When we're evaluating patients, we have to think about what is the appropriate exam for that patient, right? Is the patient conscious? Or are they unconscious, right? We're not going to be asking the patient orientation questions if they're intubated and sedated, right? So we have to know in our mind what exam is going to be appropriate for that patient. So first that we're going to sort of talk about the general considerations, right? Anytime you're evaluating a patient and doing a neurologic assessment, what is their baseline function? Do we know exactly how they were, you know, a day ago, a week ago, or an hour ago? These are all important because it potentially can change the management based on how acute their symptoms may be. You know, obviously, some of the things that we think about when we talk about a patient that's being resuscitated, what's their temperature, their vital signs, are they hypotensive? Could all of these things be contributing to why they're neurologically impaired or they're altered?
Yeah, I think as Randy said, it's really important to have an understanding if there's family or someone at the bedside. Definitely. Or reports that come from somewhere like a nursing home. Knowing what these patients look like yesterday is often overlooked. And so to be able to talk to and interview the family at the bedside and find out what baseline function is like is so helpful. So if you're the nurse or the provider that's there and family's there, getting the baseline function, home medications, those are things that are critically important from the start.
Really important. Other things that we sort of sometimes overlook are the presence of any intoxicants, drugs. Patients may be having alcohol on board, and maybe we haven't gotten a tox screen yet, and they're very early in their resuscitation. Maybe we were called to go see the patient in the ED, and that's still pending. Well, they could be under the effects of something. So we have to think about this as a global picture rather than just sort of focusing on only the one reason that they came into the hospital. Could they be hypoxic? You know, maybe they had a prolonged downtime from a cardiac arrest, and now their neurologic exam is potentially something that is affected from it. So these are things that we oftentimes need to sort of go back and think about before we go ahead and dive into why they're potentially altered.
Yeah, I think taking a good look at the patient, what do they look like when you enter the room? Do they have any, track marks? Are there any signs that there may be some other reason that there is a neurologic change? We get called about this all the time.
Right.
And then we get the labs back and, alcohol level is 500 and we have our answer. But all of these nuances, just think outside the box. Although it might look like a neurologic change, there are many other things that can contribute to altered mental status. And so make sure you just keep that in the back of your mind. Is their temperature okay? Could they be on drugs? A lot of drug screens don't even pick up some of these new street drugs that are out there. So all things just to consider as soon as you enter the room.
Definitely. Other things that we think about is the medications that we give potentially in the hospital, right? Patients come in, they're sedated, or maybe they had rapid sequence intubation, and now they have no motor exam, right? These are things that we ask when we approach the patient. When was the last time they got sedation? What was their pre-hospital sort of care up to this point? Maybe they got, rocuronium, vecuronium, one of these medications, and now we don't have a good exam to follow. So those are some things to think about. Initially, we look at electrolyte disturbances, patient's blood gas. These are just some things to browse before we have all the information for we're evaluating these patients. Mm-hmm. So as we move in, we've approached the patient, we talk about the level of consciousness, right? It's not a static thing. It's more of a dynamic thing. It is constantly changing. Patients can be confused one minute and then be obtunded the next. But really what we want to focus on is that as it's a continuum of alertness. So essentially, as the patients become more confused, more sleepy or lethargic, you're increasing the amount of stimuli that you need to wake this patient up, right? So if I'm lethargic, maybe I just respond to verbal stimuli, just Mrs. Smith, and she wakes up. That patient has a good level of consciousness, right? As I have to sort of more stimuli, if I'm more verbal stimuli, and now I have to tactile stimuli and wake them up, then that patient is sort of further along the continuum and is more and more sleepy, more lethargic, and progressive on that scale. As we sort of go down to lethargy, stupor, and then eventually comatose, we think about that a comatose patient, despite all types of stimuli, whether they be verbal, tactile, and then eventually noxious stimuli, we can no longer wake these patients up, right? These patients are comatose, and despite every aspect of what we try to do, there's no wakefulness, okay? So when we say that somebody's in a coma, that implies a very significant diagnosis. It sort of tells us that there's significant neurologic impairment that's going on that we have to pay attention to. So level of consciousness, needs to be addressed regularly as we're doing the neurologic exam and sort of followed throughout the patient's course.
Yeah, I will say, don't be afraid really to be a little bit aggressive with this. To know if someone's sleeping or they're lethargic is really important. So if it's 3 o'clock in the morning and you're not getting the response that you got 2 hours ago or 4 hours ago, turn on the lights, get in their face, give them a little bit of stim. And it's really important to tell, are they just a little bit out of it because they've been in the hospital for a week being woken up, or is there a real change here that we need to act on?
Absolutely. We're credited with being not the nicest people in the hospital because the way we wake our patients up, but it's really, we're doing that patient a disservice if we're not adequately assessing their level of consciousness, right?
Mhm.
I mean, it's just something that we have to do on a regular basis, and we don't want to inflict any noxious stimuli on patients, but we have to really get a sense of what's going on. So orientation, a lot of times when I'm asking the patients, do you know where you are? Do you know what today's date is? These are things to ask your patient. Oftentimes when we document orientation, we have to evaluate person, place, and time. And I like to throw an event. Do you know why you're in the hospital, right? If you can ask the patient sort of abstract thought, if you understand why they're in the hospital, that takes a lot of cognition. And oftentimes patients don't have good insight into why they're actually hospitalized, right, Ellie? I mean, a lot of times when you're in the hospital, patients, Mr. Jones, you had a stroke, right? And they have no.
What?
Yeah, it's like it's brand new to them. They have no idea.
But it's important. I mean,
really
these
important.
we're going in there and potentially consenting this patient. If they don't know who they are or why they're
Yeah.
here, we certainly shouldn't be using them as someone to consent for a procedure. So
Yeah.
it's really important that we know kind of the extent of their insight into what's going on medically and where they are.
And you may have checked the boxes, right? They may be oriented ×3.
Right.
They know their name, they know where they are, but they definitely have no idea what's going on. So that's really important, is to establish your insight. So what about the speech? If I ask you, can you repeat after me? No ifs, ands, or buts. That's a really good way to assess dysarthria, right? Dysarthria is the definition of slurred speech. We oftentimes will use that in place of, if the patient has a facial droop or they have mechanical issues, we have to assess if they can speak well. And a lot of times it's hard because maybe the first time you're meeting these patients, but does your speech sound normal to you? Is a really good question. Then patients have a lot of good idea of, no, this sounds abnormal. And so you can say that patient has dysarthria.
Or ask the family at the bedside. I always say, does this sound normal? If the wife's sitting there, because sometimes I think that it does not sound normal, and the family's like, yeah, that's totally
that's
fine, totally normal.
They don't have their teeth in or something,
Yeah, exactly. Do they have teeth? Most people in the hospital aren't wearing their teeth. All of those things can contribute. I think also another important point is to be able to distinguish dysarthria from aphasia.
Yeah, that's really important. So if we sort of split them up in definition wise, dysarthria is slurred speech, but I'm fully able to communicate, to create language and understand language. Whereas when your patients come in with aphasia is really the ability to understand language is impaired, right? So it comes in many flavors. The ones that we see most commonly are expressive and receptive aphasias, right? So if you're going to give some examples of expressive aphasias.
So you made a good point with saying, no, repeat after me, no ifs, ands, or buts, right?
Yeah.
And that's a great way to assess for slurring or dysarthria, but it's also a good way to assess for aphasia. Are they able to repeat back? And when they repeat back, are they saying the right words? So it's more of a phrasing problem than an articulation issue.
Right. And so that's contrasted, with receptive aphasia. Can they understand the information that's coming to them, right? Oftentimes it looks like they're yesing you and they're saying exactly what you're telling them. Oh yeah, and it's like, oh, they totally know what's going on. But when you ask them, show me your left thumb, and they come up and then they show you their hand and they're looking at it because they're confused, that patient has receptive aphasia, right?
I think another important point is when you're examining the patient, try not to use any physical cues. You go in there and
Definitely,
say,
that's
show
a
me
good
your
point.
thumb, show me 2 fingers. They may just mimic what you're doing and may not understand. So try not to show them what you want, try to just ask them.
Right.
And complex commands will really help you differentiate if they're understanding or not. If you say, wiggle your toes, that can be a spontaneous.
Yeah.
Squeeze my hand.
Yeah.
Be very careful with. It's reflexive for someone to squeeze your hand when you put something in it. Letting go, sticking out their tongue, things that take a little bit more processing, I think are helpful.
Definitely.
To differentiate.
And I'll add too, with the mimicking, it's important, like you said, not to go in initially saying, show me 2 fingers or so forth. But if your patient's having a really hard time following commands, you're having a hard time getting things out of them, you now notice that they're aphasic, it's okay to then go forward and mimic for Stroke Scale later on.
Exactly.
Just
And I
add that
think
in there.
we can't like understate that enough, is to really tease out those small
Yeah.
differences, because you can localize where, you know, lesions may be. You know, you'd be surprised at how much you can pick up on a neurologic exam just by picking up on their speech, right? Is this affecting their motor, the speech area that affects, you know, how they create language or how they're actually just talking itself?
Yeah, so much different than not being able to create the word that you want, and just us not being able to understand what they're saying because they're extremely dysarthric. And that's a very fine difference, but parts of the brain involved are much different. And so we would treat those two things much differently.
So one of the things that you know, scares everybody is the cranial nerve test, right? I mean, it's just like terrifying for everybody to think about. Oh, I have to go back to anatomy 101 or physiology and remember. But really, you're doing a lot of it very quickly, and it's very easy to do on a regular basis. When we talk about sort of breaking out cranial nerve testing, 1 and 2 are very difficult to do on a regular basis. Olfactory and optic nerve. 1, we're not really doing regularly because, you know, olfaction is difficult in the hospital. There's a lot of smells going on, but when you're in an office setting and you really want to test, we oftentimes will use coffee or something with strong scent that you can alcohol, but those are very subtle and not really used routinely. Optic nerve. So if I'm going to test the optic nerve, if Danielle's my patient, what I really want to do is sort of get a sense of what her gross vision is like, and look at visual fields, right? So if I'm going to test their vision, I'm going to have her look at my nose. We're going to cover one eye, okay? And the patient readily will follow commands, and I'll say, "Can you see 2 fingers?"
Yes.
Great. How about now?
1.
Great. And so I'm going to test all of those fields individually, and I'm using myself as a control, that my lateral vision is normal, okay? And then we're going to switch and do the same thing. So if I have her look at my nose, how many fingers can you see?
2.
Great. And how about now?
1.
Great. And think of it as a grid. You know, we're using it in a grid model. So grossly, you know, upper, lower of each eye. The way we sort of talk about it is sort of temporal and nasal, but you don't have to get that detailed. It's just really about what are the gross fields. And if somebody has a large field cut, we can pick up on that on their neurologic exam.
Yeah, absolutely. We're looking for big changes here. Anything to kind of define exactly the area, they're going to need to go see an ophthalmologist. We just want to know, is there a large portion of their vision that's missing? Right.
So when we talk about field cuts, you know, we can say the patient has a field cut, but really more correctly, we would say a hemianopsia, right? Hemianopsia is an area of the patient's vision that is impaired. And so you can break it down to a quadranopsia, which is half of that, but really field cuts are hemianopsias, which are localizing lesions to the back of the brain where our brain processes in our visual cortex, using the occipital lobes. So we commonly see with posterior cerebellar artery infarcts, we see patients that have hemianopsias. So 3, 4, and 6 all control our eye movement, and we test them together. Generally, what we're trying to look for are subtle signs. If patients have one eye that doesn't move, or potentially some ptosis, one of the lid is not moving properly, or it's just sort of lagged behind. So what I have normally do is, and a lot of times if our patients have difficulty seeing or understanding commands, sometimes you can use a big hand and just say, I want you to keep your head nice and still, but just follow my fingers, okay? And then you can sort of grossly check their extraocular motor movements in this direction. Sometimes it's hard to follow a finger, but if you have your hand, it's easy for them to see, especially when you're in a hospital room, and it's sometimes difficult to focus. So grossly, I want to check and make sure I can do them in all quadrants, sort of in a very like an eye fashion. And then you can test sort of convergence as the eyes move together, bring their eye closer. That's harder to do, and those are more subtle signs. But grossly, sort of in all quadrants, like we did visual fields. I don't know if is that the way you're doing, generally speaking? Yeah, I think it's quick, it's easy, and you just tested 3 cranial nerves in about 4 seconds.
Yeah, so exactly. It will be, I think, more apparent than you think. If you look at someone straight on, you may not notice a subtle difference, but if you're asking them to move their eyes around, you're going to notice if one of the eyes stays central.
Right.
So it will be, I think, a little easier to tease out than it sounds. We're not going to ask you, oh, which nerve do you think it is?
Yes.
You know, if you notice their gaze is dysconjugate, or one of their eyes isn't moving, or one of the lids is, you know, only opening halfway, those are all important findings.
Exactly. One of the things we also test, it's part of cranial nerve 3, but not necessarily grouped together, is our pupillary function. You know, when we're shining a light in their eye, we want to make sure the pupil reacts. And then what is the size of the pupil? How does it look different than the other? A millimeter difference between pupils is normal. We call that physiologic anesocoria. Anesocoria being the difference of pupillary size. But when it's greater than a millimeter, we start to think, okay, maybe this is pathologic now, especially in patients that are unresponsive. Now, if one eye is bigger or one pupil's bigger than the other one, that's a concerning sign.
Absolutely.
Some other cranial nerve testing, and we have a question, and we'll just finish quickly on our cranial nerve test.
In relation to your visual fields and all that testing, are you checking that every hour when you go in the room? Or is this something that you're checking once a day when you go in the room?
It's a great question. Ellie, what do you
I do it as part of my full head to toe assessment, which we do in the ICU every 4 hours.
Yeah, and you saw it's quick, right? We don't have to spend a lot of time testing this, but especially in our neurologic ICU, we're going to be doing a lot of these very quickly, very rapidly, in an effort to see, is there anything wrong? Or is the patient had a procedure that we need to really focus on their eye movements or potentially their vision?
And I would say, if you're checking anything at all, it would be pupils every single time you're in the room. Any changes in the pupils, extremely important. So if you don't have time to do a whole visual field exam, definitely at least take a look at the pupils.
Definitely. As we move further along in our cranial nerve exam, we look at cranial nerve 7, our facial nerve. It's really important for us to test, you know, what is their ability to smile, ability to sort of, you know, look surprised, frown, all of these things. One area that everybody gets sort of hung up on is the bells versus the stroke, right? I think this is even for the best and most astute neurologic provider, it can definitely look and feel like a real stroke, and I think we have to sort of go back to understanding what are we actually seeing here, right? We're looking at a lower motor neuron problem versus an upper motor neuron problem, right? So when we're testing cranial nerve 7, we're asking the patient to smile. What part of the face is affected, right? Is the entire hemiface paralyzed and they can't look surprised, puff out their cheeks, right? I have them raise their eyebrows, puff out your cheeks. You know, if they can't do that for the entire face, we think more peripheral nerve, and that's more of a Bell's sort of picture, or a Bell's variant that we see.
Yeah, hugely important. We see a lot of patients with Bell's get TPA because it's hard to distinguish between the two. Also, make sure you're looking at the eye. A lot of times in Bell's, the eye does not close. And so another kind of subtle finding, if the forehead is not moving, the eye is not closing, definitely would favor a Bell's over a stroke.
That's a great point, because these patients are coming in, they're tearing a lot because they can't close their eye. And so they have a lot of discomfort there. And it can give you subtle sort of hints at, okay, what am I dealing with? You know, and if the patient has a significant or pronounced facial droop, which is what we think of when we think of upper motor neuron, right? That's our stroke lesion. But it should really come as a package, right? Generally, stroke patients just don't have a facial droop alone. Oftentimes they'll have, you know, a subtle sensory deficit, or you may pick up on a motor deficit that may not have been there before. And so don't just think that a facial droop in and of itself may be entirely stroke. We have to look at the global picture.
Absolutely.
So in addition, as we move further along, cranial nerve 8, a little bit more difficult to test for hearing, vestibulocochlear, but you know, in patients that may have had trauma, maybe they have a temporal bone fracture and they may have significant hearing loss on one side. You know, you may find that, oh, you know, is your loved one hard of hearing? Well, no, this is new. We should just pay attention to that. Difficult to test in-house, but they really need an audiology exam as an outpatient. 9 and 10 sort of together involve swallowing, your palate elevation.
So important for our stroke patients.
Definitely, because you know it's not necessarily routinely tested, but when we do bedside swallow evals and patients can't swallow, well, this definitely could be referable to this stroke, right?
Yeah.
So cranial neuropathies involved in swallowing are oftentimes unnoticed or untested initially because we're focused on the weakness, we're focused on the speech difficulty, but the patients can't, you know, contain their secretion, they can't tolerate.
One of the most dangerous for sure.
Really, really dangerous. Cranial nerve 11, spinal accessory nerve, we can test those. A lot of times we reserve those for spine patients, but you know, the ability to shrug your shoulders, can you shrug your shoulders? And then we sort of test them individually side by side. You can get some laterality with that. And then 12, cranial nerve 12 is our testing the hypoglossal nerve, right? So that's can they move their tongue? Rare to see a tongue deviation, but we do see them with cranial nerve 12 dysfunction. But that's sort of the cranial nerves for the awake patient, right?
Yeah. I think we skipped 5 also.
We did skip 5.
Trigeminal sensation to the face is broken into 3 distributions, V1, V2, and V3. In our context, you're really probably seeing trigeminal neuralgia patients, people who have pain in this distribution.
Definitely.
Probably not a lot of acute changes in the hospital, but it's, you know, part of the package.
Definitely. Rare to see isolated, but like we're saying, trigeminal neuralgia is a common complaint. With the cranial nerve testing, lastly, for the unresponsive patient, we really want special consideration for testing brainstem reflexes. These are encompassed into our cranial nerve test, but they're ones that we test sort of independently to see exactly what brain function the patient may have, right? So let's say your patient's intubated, they haven't really done any, you know, movement, they're not waking, they have like very decreased level of consciousness. Well, what do their brainstem function look like? What do the protective reflexes look like? And what do those exactly sort of consist of? We're testing, obviously pupillary function is important, but do they have a cough or a gag, right? If they're intubated, you know, manipulating the endotracheal tube or putting a suction catheter down can assess whether or not they can cough or have a reflex to, you know, having a tube in their throat. We sort of routinely test those, but they're really important to assess whether or not these patients still have brainstem function. In addition to those, we may do some special function, also with that, I'm sorry, corneal testing. So I don't like touching the cornea with a glove. If everybody's doing that every hour, you can imagine you can cause a corneal abrasion. So just a little bit of saline, just drop it in their eye. You can get a good sense of what's happening, and it lubricates their eye as well. So if any of you contact wearers out there or glasses, you can, you know how stimulating it is to put a drop of something in your eye. That's a really good way to elicit a corneal reflex, right? So just drop some saline, take a look, and see if you can elicit a response. From the special test, if the patients have significant impairment and we're thinking about, you know, is the patient progressing to brain death, we have to test for something called cold calorics and doll's eyes, right? These are sort of primitive reflexes that may be impaired in patients that are potentially brain dead. And so what cold calorics is instilling a large volume of cold water into one ear and eliciting if there's a response with nystagmus. Not getting into a lot of details, but generally no response is that's absent. And then doll's eyes and everything else.
Yeah, cold calorics, these are kind of advanced. We won't be, you know, no one would be asking you to do this at the bedside, but just kind of warnings. Never try to attempt these on someone who is awake. It will end very terribly. It makes you very nauseous, very dizzy. Unless they're intubated and you're getting close to brain death testing, it's something you don't want to put someone through. Yeah. They won't be happy with you.
Not nice. So those, and then doll's eyes, if the patient doesn't have a C-spine injury, you're going to open their eyes and sort of move their eyes back and forth. Do their eyes move with their head, or are they focused on an object? And so in an awake patient, you know, their eyes would be focused on an object, but if their eyes move like a doll, then they've lost that reflex. Okay.
So I think we do have a question.
Oh.
No questions?
No
Okay,
questions.
before we move on to the next. So moving on now more to an awake patient. Strength testing. This is something I think is very important, but often comes through very differently based on provider. And so there are definitions for each level of strength, and it's really important that you're able to convey those to someone else, and that we're all speaking the same language, or I can go in a room, or Ellie can go in a room, or Randy can go in a room, and we're all getting the same thing. Because if we're not, it just leads to mass confusion, and nobody really knows exactly what the baseline is.
That's a great point.
So strength testing is broken into a scale of 0 to 5. This too, I test every time I'm going in to see a patient. It takes me 15 seconds, maybe. It's not a lot. 5 out of 5 is full strength, meaning If you put your hands up to theirs and you have them squeeze your hands and pull towards you, you should have equal strength. You shouldn't see any giving, and it should feel about the same for two providers who are functioning normally. 4 out of 5 means that they're still able to resist gravity, put their arms up in the air. They're able to still squeeze, but when you ask them to push or pull you, you might notice one gives more than the other. So there is some resistance, but it's not full resistance. So that's a 4. 3 out of 5, you're able to lift your arms up off the bed, but as soon as I try to come over and apply any sort of resistance, the extremity drops to the bed. So that's 3. 2, not even able to resist gravity. So a 2 is someone who's laying in a bed. If you want to, yeah, exactly. They can move it side to side, but they can't resist gravity. 1, really trace movement, very little movement, and 0 is no movement at all. So really important for you to be able to call and give us the difference. I thought they were a 4 before, but now they're a 2. Well, that's a huge change. You could give me some resistance against gravity, and now you can't give me any. You can't even lift against gravity. So very important to be able to convey what a change like that might look like. For patients who are unresponsive, I think something that's often very difficult is the difference between flexion, extension, no response. And certainly there's a gray area there, but the main difference, flexion, if you don't mind, just usually requires stimulation. So don't be afraid to get in there, a little pinch or a little sternal rub, and then you'll see the extremity move in a little bit. It's called Decorticate Posturing. Think of the core, their arms coming up towards the core, versus extension. Extension, I think if you see it once, you're not going to miss it again. It's pretty pathognomonic when you see it. Go ahead if you'd like to demonstrate. Yeah, exactly. Your arms are going out as opposed to in. So flexion and extension, very different. Both are pretty poor prognostic factors, but important to be able to tell the difference between the two. Sensation. In the hospital, we don't have all of the fancy tools. Typically, we're doing sensation to light touch. Can you feel me here? I do both sides because they may be able to feel you, say on the right, but it might be less than on the left. So I'll say, can you feel me touching? Yes. Are they the same? If they say no, then which side is more, which side is less. I do arms, legs, and also the face.
Because we want to test the sensory V1, V2, V3. Imagine just like sort of wisping your fingers around. Does that feel the same? Does that feel the same on someone's face?
Balance and coordination. In the hospital, we're not testing balance. I would say too often. It's often dangerous to get these patients, especially if they're hemiplegic or hemiplegic, up out of the bed. But coordination, cerebellar signs are very important. Just seeing if we can do heel to shin testing.
Yeah.
Just want to make sure his legs were visible.
So can you rub your heel down and then up and out? That's sort of for cerebellar signs. If somebody has dysmetria, they wouldn't be able to do that.
And then finger to nose testing. You have them, you'll put your finger out and you'll have them go from their nose to your finger. So I'll do this with Randy here. Touch my finger, touch your nose. And then you move around. If they have dysmetria,
it might put.
Yeah, I don't know if you can see that. They'll miss, they'll go off to the side, or it may take them longer. Rapid finger movements is very easy. You can do at the bedside. It's natural for whatever handedness you are. If you're right-handed, a little bit faster on that side. But someone who has a deficit, you'll be able to tell if one side is slower than the other.
And I'll add to that too, just like you're saying with being slower, sometimes they'll hit it right where they're supposed to hit it every time with their finger. They'll just kind of wave to get there, or it'll be hard for them to get there. And so kind of have to pay attention on that one.
It's subtle.
Yeah, it can be very subtle.
Yeah. Spinal reflexes, we will check in our spine patients, and we have a case later that will go a little more in depth. But typically you can check biceps, triceps, brachioradialis in the arm, patellar Achilles in the foot. That's a spinal mediated reflex. So something to keep in mind, especially in your spinal cord injured patients. The reflexive movement comes from the spine. And so it can be oftentimes kind of disturbing to the family when you tell someone that their loved one is paralyzed and then they see a reflexive movement. So something we'll cover a little bit more in our case, but something we can be checking. And then finally, as we move into more of kind of the scales that we're using, I just wanted to touch on the Glasgow Coma scale. We want to talk in numbers that we can all, a scale that everyone's familiar with. And so it's really helpful if you say, Mr. Smith came in his GCS is 15 or Mr. Smith came in his GCS is 4. Those who are familiar with GCS know what that means, but it's a scale rated on best alertness, verbal response, and motor response, graded on 4, 5, and 6 scale, respectively. I think the important things here, best score you can get is a 15. That's a totally normal, intact, oriented person. Worst score you can get is a 3, basically the same as a rock. So 0 is not a score. 3 is the worst. Kind of the decider in intubation level of alertness is about an 8. If someone's an 8 or less, you really need to start thinking about their airway. So just numbers to be aware of. You'll see largely in trauma, GCS is in every single patient. So important to be aware.
And I think with the GCS, we can communicate each other what the GCS is, but really it doesn't give us a full picture on what's happening with stroke patients. It is appropriate in certain instances, but really we want to know what their neurologic exam is, right? The GCS is a quick overview of that, but it doesn't give you the full story.
Absolutely. So we do have a couple questions that we will take before we move on to the stroke scale. So first question, would you test brainstem reflexes on an awake patient?
In a wakeful patient, oftentimes the brainstem reflexes are not tested because we have to assume that they're intact. But it is because they're very stimulating, right? You're not going to put something in someone's throat or because we have to assume that they're present. Really, when we're testing brainstem reflexes, we're assuming that a lot of the function, cortical function, subcortical function is impaired in these patients. And so if we have none of that function, meaning their motor response is poor, their eye opening is poor, then we have to move sort of from a very rostral all the way down to someone who potentially only has these left. That's the real reason that we're testing them.
Yeah,
Someone or do they still have them?
Exactly.
Yeah, they're
exactly.
awake, they're blinking, they're eating, they're clearing their throat. We can assume that their brainstem reflexes are.
Yeah, great question though.
Absolutely. Now the second one, we might need a little more clarification, just spasticity versus rigidity.
Yeah, so spasticity, having a spastic response is generally a muscle that is very tense. It's sort of constantly being innervated, where we see in patients with upper motor neuron dysfunction. Being spastic could be related to a brain dysfunction or a spinal cord mediated dysfunction. But really, it sort of goes back to what is the pathology? What are we looking at in terms of what we think the patient may have? We sort of couple that with the tone of, their tone is very elevated and the bulk of their muscles, or are they losing muscle strength is really what we think of when we think of sort of spasticity. And a rigidity is sort of something similar, but usually that means that their arm or their joint is sort of locked in place. And that may have occurred over time. It also may be referable to different neurologic conditions.
It looks like the question is a little more specific. How do you test strength on someone who's either spastic or rigid, I would guess?
That's difficult. I think patients still a lot of times will maintain some semblance of strength, but it may impair your ability to accurately assess their strength, right? If their arm or leg is stuck in one position, especially if they have a spinal cord injury, they may actually have motor function, but the muscle is so tense that you may not have an ability to sort of figure it out. And so indicating that, maybe this is confounding that or inaccurate is appropriate, an ability to test it because there's so much spasticity.
All right.
And just one more.
Yeah.
When you check your pupillary size and response, do you turn the lights in the room off or do you leave them on?
It's a great question. What do you normally do, Ellie?
It depends on how easy they are to see. Sometimes with the lights on, it's not really a problem. You shine a bright light in their eyes, you're going to see a reaction, you're going to see the size. And sometimes, and usually if they're too brisk, you can't see the reaction. You have to turn the lights off just so you can see the reaction a little bit better, get the pupils larger to assess them.
I think being consistent is important. If you're going to test their pupils, just turn the lights off all the time. Just do it for every check that you're doing, especially if you're checking the patient routinely. For us, we do it routinely. It's just easier and it takes sort of additional elements out.
The pupillary size changes more when it's dark to light than light to lighter. And so especially when you're new to this, I think it'd be helpful to probably turn the lights off.
Yep, keep things constant, and controlled for when you're actually trying to get a good neurologic assessment.
All right, I think we're going to move now to the NIH Stroke Scale.
All right. So we're going to put this up for you guys so you can kind of see it as I'm talking through this. I'm going to kind of assume that you don't know much about it. So this might be extremely redundant for some of you. And I apologize for that, but I'm going to try to give you some tips along the way of things that you can do when you have a difficult patient, when you have an aphasic patient.
Yeah.
And they're not following commands, they are ornery, all these sorts of things, right? What do you do when that happens? So some of these we've talked about already with our neurologic exam, right? Level of consciousness. This is something that you're going to assess when you walk in the room, when you say good morning to the patient. Did they wake right up and start talking to you? Or are you kind of having to arouse them a little bit? It's listed for you right next to the number, exactly what to chart. I think the difficult thing is when comatose versus a repeated stimulation patient. And the hint that I'll give you here is localization. So we were talking a little bit about the GCS, about Decorticate and Dysarthria and things like that. When it comes to withdrawal versus localization, you sort of want to imagine a line down the center of your body. And if you were to, let's say, pinch somebody on their left arm, is their right arm able to get across that middle center of their body to reach across to get to that left side? That's what localization means. Not only do they know where you're pinching, they're not just pulling away from it, they're reaching across their body to get to you. So if your patient can still localize, even if they're not opening their eyes and they're not following your commands, they're not a 3 yet, they're not comatose yet. So that's what I'll say there. As far as level of consciousness questions, when we're there first thing in the morning and then throughout the day, we're used to asking these orientation questions, right? Where are you? What month is it? Things like that. And it all the way includes up to situation. For the NIHSS, however, while we want to know all of these things as part of our neurological assessment, we want to make sure 2 of those questions include what month is it right now and how old are you? And the reasoning is those are the only 2 that you're going to score for this scale itself. Okay. It doesn't feel right. It's very unnatural. We're used to asking for things. It's the way that it was designed. So it's what month is it and how old are you are the only 2 questions that count for this. And then it'll tell you, 1 question correctly, 2 questions correctly. It's not an average. Following commands, we ask them to close their eyes very tightly and open them wide. The reason we use that as one of our commands is this is going to help us later on in facial palsy to assess whether it goes all the way up to the eye. So we're kind of able to do 2 things at once here. And the other thing, like Danielle was saying, when you ask somebody to squeeze your hands shut, that's not the command. The command is then opening their hands. That's the command portion of it. Because like she said, when you put your hand in somebody else's hand, it's a reflex to squeeze. You see it all the time with babies. And again, that's really hard for family members to see. You're telling me that they can't move purposely, but their hand just squeezed open. And so you want to make sure you have them open their hand as their second task. Best gaze, we talked about mostly though, the extraocular movements, right? So you're going in diagonal, you're going up, you're going down, right? For best gaze, it's just side to side. So make sure you get that in there when you're doing your exam. Can they go one side versus the other? It's only horizontal. When your patient is not answering your questions, not following your commands, doesn't want to do what you want to do, you kind of have to warn them ahead of time because you're going to have to put your hands on their face. And he was talking about the doll's eye maneuver. We're essentially going to do the doll's eye maneuver, even though we're not testing brainstem or anything like that. You're going to hold their eyes open and turn their head to either side, slightly briskly, but not breaking their neck. And if their eyes are staying fixed on you, which they should, right? That'll tell you, can they go to the, if you do it on yourself, right? Look at the light on your ceiling and turn your head to the left, your eyes stayed on that light, right? And you could feel that your eyes can go to the right, and then turn your head the other way, your eyes can go to the left, right? So they're able to go both sides. They have a normal gaze. Visual fields, he was talking about our sort of four square here with our hemianopsia, right? So this is really, really difficult for people to score. And I don't know why. It used to be really difficult for me to score too. The easiest way, well, yes, our center field of vision is intact, so it's not entirely a four square. We're just going to pretend that it is. If one of your squares is out, right, they can't see in that portion, then that's a 1, right? Imagine it's out of a 4, even though it's out of 3. If 2 of the squares are out, then it's a 2. If 3 or more are out, it's a 3, right? Now, in the NIH, it's very, very annoying, but it is the way that it is. We score for baseline, right? So we were talking, for instance, slurring. Does their speech sound normal to you? Okay, well, it didn't sound normal to me. Maybe they had an old stroke, maybe they're slurring, so on and so forth. Regardless, for the NIHSS itself, if they're slurring, even if it's how they sounded at home. And the reason that you do that is, let's say you're signing off with the nurse coming on, it could get missed that this patient has this baseline slurring, or maybe it did get worse, or maybe it did get better, and things like that. So the thought process is, when I sign out to you in the morning and another shift comes in that night and it's not me, we're going to get the same score regardless. There is no miscommunication. There's no error in that. So that's sort of the thought process. I get it. I don't like it, but I get it. Okay. So with visual fields, this is the only exception, being that because it's hemianopsia, it's not central vision and things like that. Your right eye, if it's from the stroke, is going to be the same as your left eye. And that's why we test them one at a time, right? So if one eye is blind at baseline, glaucoma, cataracts, so on and so forth, the National Institute of Health says we're allowed to just test the one good eye, because if that had a problem, then the right eye would have had it too, if that makes sense. The other thing I'll say here is they've built in sort of a cheat if your patient has neglect. We all know what neglect is, right? You neglect one side of your body, or you neglect the other side of the body. When you have a patient who has neglect, you can imagine, let's say I forget one side of my body exists. I'm not going to move that side. I'm not going to look at that side. I'm not going to feel that side. All of a sudden, you can kind of count up in your head just by looking at this NIH, how many points they're going to get, right? Just for that one thing. So they've sort of built in, and they only do it in visual. I don't know why, but they do. Regardless of what they get for your visual score, if you find throughout your test that they have neglect, you're going to change that score to a 1. And this is something that I learned recently, and I was glad that I learned it, because it does help, and it kind of counteracts a little bit that score that they're going to get. Facial palsy, you're not going to really be able to see my face here, but I'll sort of show you when we're doing an example. You score it based out of a 3. Oh, you can see me now. Okay. So a 1 is just the nasolabial fold flattening, right? That's that little crease on the side of your face. Okay. If just that is flattened, you barely notice a facial droop, it's just a 1. Sometimes they can even correct it, right? You'll just see it at rest, but they smile big enough and they're happy enough, they're almost correcting it, so you're not sure if it's there. That's your 1. A 2 means the whole bottom of their face is flaccid, right? They're not able to lift, they're not able to puff out their cheeks. When they do, kind of pops right through, right? And then a 3, we're talking about lifting your eye, closing your eyes shut, opening them wide. Are they able to lift up their eyebrows? If it goes all the way up to their eye, it's your 3, okay? So that kind of makes it a little bit easier to score if you think about it that way. Think about your hand.
Great.
All right, back to drift. This is the one that gets everybody upset. It's very different than muscle strength. Muscle strength was on a 0 to 5. This is 0 to 4, and it's the opposite, right? The higher score you get, the weaker you are. And in addition to that, it's only based on purposeful movement, okay? I'm gonna say that again. It's only purposeful movement. If you are comatose in the bed, if you got a 3, you are not localizing, All I can do is pinch you in withdrawal. Okay, yeah, your muscle strength is so on and so forth, but you get a 4 for drift no matter what, okay? If I can't say to you, lift your arm off the bed or hold your arm up for you, and you hold your arm up off the bed, then you have no purposeful movement. I wish it said that in your, see how it just says no movement? I wish it said purposeful right in there, but it doesn't. The other thing is, just like I was saying earlier, you're gonna score for baseline. So if your patient had an orthopedic procedure and they can't get their leg off the bed, or they can a little bit, but that's all, you have to remember, if they can't do it at 7 a.m., they're not going to be able to do it at 7 p.m. when you leave for the night. Or, you know, when Randy's in there on Tuesday and then Danielle's on there on Wednesday, they're going to get the same exam. Okay, so that's the reasoning behind that. So they're going to get a pretty high score for baseline things, and we just sort of have to accept that. Our job as nurses is not necessarily to assess whether the patient had a stroke or where they had the stroke, right? We're looking at, is there a change? Do I need to call? All right, are they getting worse? We like to know also if they're getting better, right? But it's not an assessment. It's not an MRI. You're not giving somebody points or a bad grade in big red letters, okay? It's just a number, and just think about it that way. For patients who are aphasic, you are going to have to hold up their arm, and you are going to have to mimic for them to remind them to keep it up. And they're usually able to do that pretty well for you. If you just keep putting it back up, they'll get the picture. And then you can sort of count down for them. I don't think I'm forgetting anything on that one. I'm going to move on to ataxia. We were talking about uncoordination, right? Your finger to nose and your heels on the shin. When you're testing for ataxia in the upper extremities, just make sure that your arms are extended fully when they reach out and they touch your finger and touch the nose. The reason being, your arm can sort of brace itself against your body, right? And so if it does have weakness or uncoordination, you're going to see that. I mean, your eyes are open. And so it's our body's natural response to correct that and to make it better. And so just if you notice that their elbow is sort of kinked when you're going and you touch the finger, just kind of take a step back and allow them to fully extend. The other thing on this is that it's out of proportion to weakness, right? So if they have difficulty purposefully moving with their drift, with their arms or with their legs, you're gonna keep in mind that extremity, if it's very weak, you're not going to score it for uncoordination because you already know that it's really weak, okay? So they're weak, not uncoordinated. So this isn't untestable or anything like that. They're going to get a 0 in that extremity that's weak, and you're going to continue to test the other extremities that are strong. I will say though, if somebody only has a drift of like a 1, if it's very minute, you know, you're holding your arm up for 10 seconds, it drifts down a little bit, it never hits the bed. I would still test that extremity because you can always have coordination issues on top of it. Maybe they had a stroke in the past, so they have coordination problems now, and they had weakness problems before. So you don't want to miss that, right? So if it's grossly uncoordinated and they only had a drift of a 1, you're still going to score for it, if that makes sense. And then the other extremities would be the lower, right? So you're going to do heels on the shin up and down. Sensory loss. If your patient is in a coma, our natural ICU response is, well, I'm pinching them and their heart rate went up. They can feel me. I understand. I get it. I'm right there with you, but my opinion doesn't matter to the NIH. If they are in a coma, they get a sensory score of a 2. 2 would be that they have a severe total sensory loss. Their reasoning behind it is that they're not aware of you touching them because they're in a coma. I'm just going to leave that there. 0 would be no sensory loss, right? Best language. This is where we show people a picture. We say, describe to me what's going on in this picture. Tell me what these objects are. And then repeat after me. You can imagine if your patient's blind, they're not going to be able to show you a picture, right? And then it's our natural inclination. Wow, there goes the whole NIH because I can't test it, right? So what you can do in that, moment, we're in a hospital, so there's lots of things at the bedside, right? They've got their cup, they've got their phone, they maybe have a pen sometimes, or their call bell or things like that. Have them touch a blanket, put them in their hands and ask them to tell you what they are. When you're asking their orientation questions to situation, you heard them tell the story of how they came to the hospital, why they're in the hospital. So you can hear their fluency of speech. That's an aphasia or a phrasing question. And then those fun questions, those repeat after me, say mama, tip tap, that's a repeat after me. That's not a read off the page. And so they're still able to do that. Repeating back is a way to test for a language issue. Not everybody is aware of that. So you can have them repeat back. And that's going into that. When you're repeating back, that's your articulation as well. You're testing two things at once. Are they having slurring? How bad is it? As far as the best language for your comatose patient, you see number 3, it says mute or global aphasia. If your patient is intubated and not speaking to you and not alert and looking at you and so forth, they're going to get a 3. Very rarely you're going to have a patient who is alert. Maybe we're weaning them off the ventilator and they're able to nod yes and no and things like that. They're going to score a lower score. I believe it's a 1 actually, that they're going to get. So it's the little nuances of it. My best recommendation would be to get either a little pamphlet or a printout and just keep it in your pocket. If you are somebody that's either doing NIHSS frequently, or even if you're a med-surg nurse and maybe you've had to call a stroke alert before and you sort of panicked while you waited for the neurologist and the ICU nurse to get there. I don't know how to do this confidently, you know. That's something that you can have with you and whip out for that rare occasion. So you do know how to accurately score it and you do know what the questions are. And, you know, maybe you'll hear me talk about this and then you don't have to do it again for 2 years. So just keep it with you. That's how I learned. That's how most of us learned. And just like I learned this visual trick for neglect just this year, you're still going to be learning all the time. So dysarthria, if they have mild to moderate articulation issues, they're going to get a 1. If they're going to have severe dysarthria, it's going to be a 10. Also, sorry, I just looked at the number. It's going to be a 2. If they're mute, if they're intubated, they're also going to get a 2. Okay. Extinction and neglect. This is whether they're acknowledging one side of the body versus the other. I think that's pretty pronounced. And pretty obvious when you do see it finally for the first time. It's always one of those things. Well, how do I test for it? How do I know it's going to be a real thing? As you're going through your test, my biggest recommendation is to walk around the room as you're testing. It kind of helps you do 2 things. One, if your patient's not following your commands, you're going to see whether their eyes can go to the right and to the left, right? If you're walking from one side of the room to the other. They're going to, sometimes you'll walk around right to the left side and they just stop following you and stop answering your questions and forget that you're there anymore. And then you sort of walk back across their midline and all of a sudden they're like, oh, you came back. And I'm like, I was right there, right? That's neglect. The first time that you see that, you're going to know exactly what it is. And then just remember to go back to the visual field and change that score to 1, give them a little something for that. I'm going to pause here and see if I have any questions to see if I forgot something important.
Yeah, you guys do have a couple of questions.
That's
so
all right.
The first one is in regards to testing localization. Would you test on the lower extremities and what would that look like?
Would I test on the lower extremities? I guess you could. Are you thinking if the patient's weak on the upper?
I think it's hard, sort of like when we sort of talk about localizing for lower extremities, it's hard to say if somebody can localize, but really, are they purposeful in the lower extremities, sort of spontaneous? That's really helpful to sort of understand. It's hard to sort of find a stimulus and then remove it. That's really what definition of localization is. So for the lower extremities, if you sort of give them like tickle their foot, or then they'll actually remove their leg or just be very purposeful. Those are sort of synonymous with localization.
So the next one that maybe you could elaborate on too is just kind of the fact that the NIH is poor at picking up a posterior stroke.
100%.
Sure.
Trying not to talk about how much I
Aware.
dislike it.
Oh,
Yeah.
yeah, it's hard. Posterior fossa strokes and posterior circulation strokes. What we refer to those as, for those of you who aren't aware, are strokes within the brainstem or vertebrobasilar strokes that affect those areas. Really, these patients look like they're comatose, or they may just feel dizzy. They may want to throw up. It's hard to really assess, and there's nothing on there. And we agree with you. It's not a sensitive test for picking up posterior circulation stroke. And so really what we try and stress is having the suspicion that it could be is really going to put you in a good place to make the diagnosis.
Yeah, it's a screening tool, and none of these stroke screening tools are foolproof. And so we just, and as Ellie has been saying, it's important that we are able to assign a number, but more important that two people are able to reproduce the same number or similar number, because what's the use of the number if we can't determine when it's changed? And so it's really important. We know this is subjective. People get very frustrated with this scale because of that, but really we want to assign a number. We can communicate, oh, 5, not so bad, 25, bad. Everyone can kind of get a feeling of where the patient is before I look at a patient. If their stroke scale is 25, I know I'm not going to walk in there. They're going to be walking around the room.
Yeah.
It's important that you're doing the scale together. When there's change of shift, neuro changes, very popular at the change of shift. It's because of these nuances, and I gave a 3 and I gave a 1, and now my scale has changed. And so it's important that as a nurse, especially when you're handing off to the next nurse, you should be examining that patient together, agreeing on a number or disagreeing on a number. That's okay. But the important part is, well, I thought that was a 3 and I think it's a 2. That's fine.
But yeah, we're looking at the things together, and that's the same droop.
Yes.
So we're good.
The patient has not changed. And so small changes in the stroke scale aren't a big deal, but a big change is a big deal. And that's kind of what we're looking for here. If someone goes from moving their arm to being plegic, the scale is going to go up. And so it's just important to remember. I know that it's frustrating, but making sure you're doing it with your colleagues, especially in nursing, and just making sure you're looking at the patient. It's about the patient. It's not about the number. It's not about the scale, but they're just tools to help us. So make sure you're communicating with whoever you're getting handoff from, and you're looking at the patient and knowing if there's really a change, or you guys are maybe just, looking at the numbers a little bit differently.
Good question.
So the next one is, when a patient has a baseline deficit that gives them a higher NIH, do you add a caveat note as to what their scale is at their baseline versus what it is now?
It's usually documented somewhere that they have this baseline, whatever it could be, weakness or things like that. And so I don't necessarily make up an NIH and just sort of put it in and say, well, their baseline is 7. You could go back and look at their discharge instructions. It'll say in there what their baseline is. But a lot of times in my neuro assessment or my neuro note that I do in addition to the NIH, I'll put in there somewhere that, they have dense sensation to their left lower extremity because of whatever from the baseline. But it's, again, we're not using it as a treatment. We're not using it as a diagnosis as nurses, right? This is more looking for, is there a change or is something happening right now? And that I need to call the physician about. So because we don't have to make decisions on it like that, it's not as necessary that that's written exactly where the NIH is.
Good question.
It looks like just 2 more. So how do you differentiate dizziness due to a stroke versus dizziness due to a vestibular dysfunction like BPPV or Meniere's disease?
That's, to say they're very difficult. I would lean on our, neurology colleagues who sort of see patients that have benign diseases like vertigo, like BPV, or patients with recurrent symptoms. Also, trying to understand the acuity. Had they had symptoms like this before? Is this a new symptom? Generally when patients experience vertigo, or do they have tinnitus? Is this, characterized as something that may be new? May help you sort of, is this an acute stroke process or is this something else? It's very difficult. I have to agree.
It's difficult. And that's why we have advanced imaging.
Yeah.
But I think some key features of vertigo, with change in position, you may have a room spinning sensation, that sort of thing, or they'll say, oh, this has happened to me 3 times in the past and it feels the same every time.
Yeah.
But largely it is hard to distinguish without any image or other advanced intervention. And so sometimes people get MRIs in the ear just for this, just to make sure, because worst case scenario, you're having a brainstem stroke, and otherwise it could just be benign vertigo. And so it's challenging for sure. It's definitely one of the gray areas. Makes people kind of nervous because it's hard to differentiate.
And reach out for help. I mean, we do it all the time. You know, consulting someone who's more knowledgeable in this than you is what we sort of rely on. And if there's an area that, you know, I'm kind of confused about this, or their diagnosis, I may be suspicious for other things, ask the experts. You know, it may be helpful.
Yeah, neurology, ENT, physical therapy is great.
Yeah, definitely.
How would you approach a patient that's coming in with only sensory symptoms in an arm or a leg?
So that's a great question. That a lot of times
A arm or a leg?
An arm or a leg.
Yeah, just one, not both. Yeah.
Usually pretty low on the NIH, right? If they're pure sensory. Generally, when it avoids motor, sensory, speech, all these things, we don't think of being a large territory stroke or something that may have a large occlusion somewhere. Those may be referable to lacunar strokes, small vessel disease. And so the treatment may be very different. You know, we're not calling the entire team to come in and potentially do a procedure on someone with a very low NIH with just a pure sensory deficit.
Yeah, I would say also you have to keep other things in your differential. If I come in and say my right arm is numb, well, is it in, you know, a specific distribution? Could it be coming from my neck? Is there a peripheral nerve that could be involved? Is it the whole arm, part of the arm? All of those things. Is the face involved? That's a great way. It's pretty odd to have just a sensory loss in one extremity with no facial involvement. So all things I would look for to try and differentiate, where is this lesion? You know, where is it coming from? Is this benign? They, you know, hit a peripheral nerve, they bang their arm, or is this something that, you know, is a warning sign for a stroke?
And if it may not like be readily, you know, overly disabling, you have some time to work this up. You know, the relative acuity, if their symptoms are, you know, their symptom severity is low, just as a sensory deficit, that's not a disabling feature outright of somebody with a diagnosis of stroke. And so oftentimes their workup may be over 12, 24, 36 hours until we kind of come to a diagnosis, but exclude some of the life-threatening things.
Yeah, my exam may change a little bit. I might test muscle groups. I might test sensation a little bit differently, reflexes, all things that could help point me in another direction too.
Yeah.
I actually have one more that popped up that I think is good to answer, because it's a question that I think you get from a lot of nurses that maybe don't take care of neuro patients a lot too. Are you doing an NIH assessment for stroke patients only, or also patients that had maybe an elective brain surgery or a tumor resection?
So you're going to do a neuro assessment on all of your patients, right? But the full NIH stroke scale was specifically designed for stroke. So that's something that you're going to do as a handoff with another nurse at the start of your shift for only your stroke patients, right? So your ischemic, your hemorrhagic, your TIAs.
Yeah,
Good question.
Yep.
I will hit on before we continue for ataxia. If your patient is blind and they're not able to do the finger to nose movement, it's a self-awareness thing that we all know where our nose is, right? So if you pull their arm out and tell them to just do a pointer finger and ask them to touch their nose, they're going to be able to do it perfectly. So if they miss at all, that is going to be a coordination issue.
Awesome. Good tips.
Yeah, I think before we move on to the patient case, we did just want to mention the MEND exam.
Yeah.
And some other workshops that we have that can help you, you know, with your stroke diagnosing.
So one of the courses that we offer and we've been teaching and sort of increasing in its popularity is the Advanced Stroke Life Support course. From the University of Miami, is a peer-reviewed sort of evidence-based opportunity for a different type of scale, a rapid scale that will allow you to evaluate your patients similar to a GCS, right? We sort of do GCS reflexively in patients and we document them. But the MEND has components of the NIH that are more honed in on major stroke deficits. And really, as you can see here, it's sort of broken down between mental status, cranial nerve testing, and limbs, focusing on really the key aspects. Are they abnormal or normal? And then really, can you localize the lesion from the MEND exam. And we found that when we teach these classes, the answer is yes. A lot of times we teach stroke syndrome solely based on what their MEND exam is like.
Yeah, you'll see EMS uses the MEND exam a little more frequently. They certainly have a lot more going on, a lot less time to get into the details of a stroke scale while they're bringing the patient to the hospital. So you might hear them communicate in these terms as well.
And the difference isn't even necessarily the scoring. You'll notice that right away. It says check if abnormal. And so what's quicker isn't even necessarily the charting aspect of it, but how they test. It's much less laborious. You're not, for instance, when you test arms, you're not doing one at a time, right? You're doing them at the same time. So it's just able to see the same sort of thing in a much shorter period of time.
So if you haven't heard of it, it's a great addition to scales that all providers can use. And we've been teaching it through our courses. So you can learn more if you visit the ASLS website.
Yeah, another helpful certification is the ENLS. It's available through the Neurocritical Care Society. It's an advanced neurological life support class, very comprehensive. It goes through many chapters of different kind of algorithms of what to do for patients with neurologic problems or injuries. I find it very helpful. We actually have all of our staff complete it. So something, if you're looking to have more information and get certified, you can get CMEs, something you should also take a look at.
Yeah, it's great. I think we'll move on to sort of do some cases.
Yeah, so we're going to move to our first case. So we've discussed the stroke scale, and now we're going to put that instruction into a real life patient. And so Ellie is going to examine Randy here, and our first patient, a 58-year-old male who comes into the emergency department with a new onset facial droop with left-sided weakness. This started about 6 hours ago. He was outside mowing the lawn. His wife noticed it, thought the weakness was getting worse, and his slurred speech was getting worse. So she calls 911. And Randy comes into the emergency department. EMS tells us, per his wife, he has atrial fibrillation. He takes aspirin, hypertension, some orthopedic surgery, no other major surgeries. He takes some blood pressure medications at home, lisinopril and HCTZ, and he has no allergies that she knows of. So he comes in initially. You can look at his vital signs. Blood pressure is 166/85. Heart rate's irregular, 67. Respiratory rate is 12. Satting 98% on a non-rebreather, and temps 99.5. So just a quick look at this patient. He's on a non-rebreather, satting 98, so he's in some distress. You don't see any obvious signs of trauma, something you should always look for in stroke patients. If you become densely hemiplegic, you're likely to fall. So something you should keep in mind. And then we know that he has a forced right gaze, irregular heartbeat. He does have the history of atrial fibrillation. Lungs sound okay. We get some imaging. He's in the neuro ED. He gets expedited. He gets a CT, a CTA, and an MRI. And so we get the MRI results. And you can see here this bright white section on the slice of MRI. So keep in mind, the imaging is reversed. So what's on your left is actually the right, and what's on the right is the left. And so we see this very bright portion on the right-hand side here. And that's, unfortunately, this man's very sizable right MCA infarct. And so we know what's going on based on his scans, but we want to go through the neurologic exam here. So Ellie's going to walk us through a stroke scale.
You can see me. Good morning, Mr. Faber. How are you doing? Yeah, my name is Ellie. I'm going to be your nurse today.
Okay.
You feeling all right? Okay, so I'm walking in, his eyes are open, right? He's responsive to me. He's answering questions. Just can't kind of understand him very well. You can see very noticeably, he's ignoring one side of his body, right? Oh, you're right there. Sorry. He's noticing one side of his body only. So now noticing that, I'm thinking, I think this guy's got some neglect. So I'm going to move over here into his field of vision, right? So he's able to acknowledge me for the rest of the test. Mr. Faber, can you tell me what month it is? Say it again. June. It's June. I'm thinking November. All right. So he gets a 1 for that. So right now he's alert. And he's got one question wrong. Can you tell me how old you are, Mr. Faber?
75.
75. So he's very confused because he's 58. He's aging himself. Okay. So he's already got a 2. Following commands. Mr. Faber, can you squeeze your eyes real shut for me? Really tight. Okay. I don't notice any drooping. Can you open them up for me? Very good. And let me see. You squeeze my hand. Can you squeeze my hand really tight? Very good. And let go. Good job. I'm going to have you squeeze over here too. I'm going to lift up your hand. Can you squeeze my hand? You guys can see that he's not moving that side at all, right? So while I'm over here, let me just go ahead on over to drift. Mr. Faber, I'm going to lift your arm up in the air for you. Can you hold it there? I'm going to let go. I need you to hold it there. See how I have my hand underneath of his arm? If I were to let go of this right now, it's going to smack and hit the bedside table and we're going to have a lawsuit. All right, I'm going to hold your arm up. Keep it up there for 10, 9, 8, 7, 6. We would go all the way down to 10, right? This is just one at a time. One thing I'll point out with neglect, he's neglecting this so badly. If your side rail's down, it's going to fall off the bed. It's going to get caught, so on and so forth. Make sure you have that left side supported when he's not able to take care of it himself. The same thing is going to go when you bring in his breakfast tray, right? You're going to want to make sure it's on the right side of his body. When you're talking to him, when you're showing him things, you're going to want to be all the way over here on the right because he's not going to acknowledge that this exists. Okay. Mr. Faber, we're going to move over to your right arm. Can you lift up that right arm for me? And keep it up. Don't let it fall. All the way up. Really good. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good, and relax. All right. So now we're going to move on in order and do our gaze preference, right? I don't know if you're going to be able to see him here, but right now he's looking over here at the right. He's looking down here at the floor, okay? Mr. Faber, can you see my finger? I'm going to have you follow it with your eyes. Ready? Just your eyes. Follow it over here. Good. Go all the way over. And he's staying right where he is. So he's got a right gaze preference. That's what we call it. Okay. Visual fields. I'm going to have you look at my face. Very good. Can you tell me how many fingers you see? Make sure you're actually in their peripheral vision. I see a lot of people go back here. If you do that to yourself, you can't see it either. Also, if it's all the way out here, maybe I can see your hand, but I can't see how many fingers you're holding up. So make sure you're actually in their peripheral vision. How many fingers do you see now? 1. Very good. How about now? 2. Very good. How about now? 1. Very good. We're going to do it on the other side. How many fingers? How many fingers? 2. Very good. How about now? 1. How about now? No. No. How about now? No. So he's not moving the left side. He can't see the left side. Now remember, we're thinking neglect, right? So normally we would give him a 2 for this, right? Thinking, well, he can't see either of the quadrants on the left sides of his eye, right? But knowing that he has neglect, we would just score him a 1. We already did our arm drift. We're going to go ahead and move down to our leg drift. Can you lift up your right leg in the air for me and keep it up for 5, 4, 3, 2, 1. Good. Go ahead and put that down. Can you lift up that left side for me? Okay. All right. Go ahead and do it. All right. I'm going to lift it up for you. You ready? Keep it up in the air. Don't let it fall. 5, 4, 3, 2, 1. The legs are just 5. The arms are just 10. Sorry, I keep looking at my notes because I'm used to doing it my way, not in the order that it's supposed to be done in. Don't tell anybody that I don't do it in order. All right, we're going to see your coordination levels here. Can you show me your pointer finger? And reach out and touch my finger here. Can you see me? Good. Right on the tippy top. Good. Now touch your nose. Touch my finger. Touch your nose. Good. Now, normally I would move my finger all around, but he has very limited vision here, right? So if I just do it multiple times in the same spot, that's okay. You're just looking to see how is his coordination. It's not do it 4 times, do it 1 time, okay? You just want to get a really good picture. So that side was good. We know he's not going to be able to lift up that side. I'm not even going to try. Mr. Faber, can you bring your heel up to your shin and rub it up and down for me? Very good. And relax. And again, this leg is not moving, so I'm not going to test it. That side would score a 0, so he scores a 0 for uncoordination. We've already heard his speech a little bit, but I'm going to delve into a little bit further. Mr. Faber, can you repeat after me? Say mama.
Mama.
Say tip top.
Tip top.
Say 50-50.
50-50.
Say thanks.
Hey.
Huckleberry.
Huckleberry.
Baseball player.
Baseball.
Baseball player.
Baseball player.
Very good job. So we're able to understand him, but he's pretty slurred. Once he gets to unintelligible and I can't understand what he's saying, but he's still saying speech, that's when he would be a 2. So we're going to give him a 1 here. For as far as aphasia, he was able to repeat back just fine. So now we're going to have him read some sentences. Can you read these sentences for me?
You have flown the earth like a home for work, the restroom.
Near the what?
Near the table, they heard him speak on the radio. I got most of them. Last night.
There's so many words. I'm going to show you some objects and I want you to name them for me, okay?
Love, Faber, key, hammock.
Very good. All right, so I'm not noticing any aphasia. I did notice that I didn't ask him to smile. I just did the eyes. Can you smile real big for me? Very good. Now, if they're having a hard time and you still can't notice with the smile, you can have them again puff out their cheeks. That's a really good indicator too. And we already know that he's fully neglecting that side. So that's how you would do it. Not as complicated as it seems.
No, thanks. That was great. I think that's a great display of the difference between someone who's severely dysarthric and someone who's aphasic. And so we couldn't really understand a fluent sentence from him, but we knew that he was able to sound out some of the things on the paper. And so it's not a production of language problem, just kind of a movement problem in his mouth.
Yeah, and that's sort of part of the right MCA syndrome, the sort of package when patients have a large stroke on that side. So we expect some of those exam deficits to be present, the neglect specifically, but the weakness, sensory deficit, and speech that we sort of saw earlier.
Yeah, so it's pretty classic MCA syndrome. Any questions on that one? No.
All right, move on.
All right, we'll move on to our next case. So someone has kind of brought this up before. So we have a 55-year-old male who comes to the emergency department. His initial complaints are intractable nausea and vomiting with dizziness. He was at work. His coworkers found him kind of confused, slumped over on the floor. Not really sure when he was lasting normal, but he only came to work 3 hours ago. So we can't really get any more specifics than that. Although his coworkers say he's been off all day. Hasn't been acting right all day. We find his previous information from last time he was here. He has high blood pressure, diabetes, gout. He's had an MI in the past with a stent and tobacco abuse. So he's checking off a lot of boxes here on risk factors for stroke. He had a cardiac stent back in 2015. So, you know, we can infer, even if we don't have his medications, he's probably on some sort of antiplatelet. What we find is aspirin 81. He takes metformin, a few blood pressure medications, something for his gout. He's allergic to penicillin. So he comes in, his blood pressure, it's high, 185/90, heart rate's 82, respiratory rate's 20, statting 97 on 2 liters. So he's really not in too much distress, but his blood pressure's high. Something important in stroke patients, some people may see that number and think, oh, we need to treat his blood pressure. If you think this patient's having a stroke, move on to the exam and some other things before you think about dropping that blood pressure, because you might actually do them a disservice. So he's drowsy. You're looking at his eyes and he has a disconjugate gaze. His pupils looking a little bit sluggish, regular rate and rhythm, lungs sound good. You send him off to CAT scan for a stroke alert head CT. And then the RN calls you when she gets back and says, you know, before he was talking to me, he was really nauseous, but he was able to talk. And now he's really only responding to deep stimulation. He didn't get any meds for the CAT scan. Can't really get him to consistently follow commands. I think he looks worse. Now he's not protecting his airway. He's drooling. And this has progressed significantly. He's only been in the ER 10 minutes and we've gone from awake alert with some nausea, vomiting to now he's, GCS is becoming less than 8. And so
It's very concerning.
very
Yeah.
concerning.
Red flags everywhere, right? We're all
Yeah.
thinking,
But we're asking him, so we'll move on to the neurologic exam. So he's drowsy. He was alert, but now you need a deep stimulus to have him really participate in any sort of exam. You have to intubate him. He opens his eyes, right side's moving spontaneously, left uppers a 1, left lowers sometimes bending and sometimes not. It's really hard to get him to participate. He's not following commands, but you can note some spontaneous movement on one side. Stroke scale is a 20. So this is really a really concerning presentation, and I think a presentation that's oftentimes missed or misdiagnosed. Someone who comes in with posterior circulation symptoms.
real case, by the way.
Yeah.
So this is patient that we actually saw. And you can see how rapid these people can progress. Their stroke scale is high. We're trying to figure out what's happening with this patient. We're rushing to CT to make sure the patient didn't have a bleed. But really in an effort to try and figure out, are we missing something? Is there something going on with this patient?
Yeah, this is something just to be aware of. I think a lot of times nausea, vomiting, dizziness, people don't connect that dot to. This could be a posterior circulation event. And while all strokes are, of course, serious, posterior circulation goes downhill quickly.
Yeah.
And we're talking about the brainstem. That's very, high priority real estate there. And if you get damage there, it's irreversible and oftentimes incompatible with life. So if you see a patient who looks something like this, I think it's, at least have on your differential, could this be a stroke?
Right.
So this is an actual patient. He was transferred to us. Here are some of his films. Came through the emergency department, went straight to the CAT scan, got a CT angiogram, which is the image in the middle there. What we're looking at is the basilar artery, and I can't really point here, but in the middle of the basilar there, you see this dark area, and that's consistent with a thrombus. On the right, on the CT of the brain, this dark areas in the back are actually completed strokes. So when he came in and had a stroke alert head CT, we saw those strokes. We knew he was having a stroke. It was probably posterior circulation, but you won't always see that. Strokes don't show on CAT scan immediately. So you may or may not have that finding, but it was helpful for us and helped guide us to fly the patient down to Crozier to deal with this urgently. So he has this. Now it looks like at least a partial basilar thrombus with strokes in the posterior circulation and a rapidly declining exam. This is a patient that goes for intervention. So he is taken for intervention. The picture on the left is his cerebral angiogram. They were able to open his basilar artery, and then he was admitted to the ICU after.
Oftentimes these patients are very disabled. You saw his stroke scale was high, right? And so we think about, can we localize this? But the brainstem, it's very, very difficult to sort of try and discern. Their stroke scale is high. I don't know what's actually going on. And it could be a lot of other non-stroke things. But when we get advanced stroke imaging, it really gives us a sense of what's actually happening. Are there any large vessel occlusion or stenosis that potentially could be causing these patients' symptoms? And we got a hint from the patient's CT, that there's something going on.
Yeah, so I think helpful to see that, an NCA stroke behaves much differently than a posterior circulation stroke. But it's good to have on your mind, good to have a differential. So critical that you can perform these screening exams on the patients and be able to communicate. You're the nurse in the ER and you think the stroke scale's 24 is much different picture than you think the stroke scale's an 8. And so we can't see the patient always. And so our eyes and ears are everyone else. And we just wanted to go through everything so everyone feels comfortable with this. And so we're all speaking in the same terms.
And it's a constant learning process. I mean, I feel like I'm learning something every day. I'm sure you guys are as well. There's always something that we can identify, a new finding, do something a different way. So there's no single way to do this, no single way to examine these patients, but really sticking to the fundamentals of some of the sort of things that we talked about, being systematic, going through sort of putting it all together, becoming efficient of how you do things. We can do a quick neurologic assessment in someone, 35 seconds, maybe a minute,
Yeah.
and we can really understand what's happening with these patients. And it's so important that the folks that are treating these patients have a good understanding of how to do it as well.
Yeah, you get a lot of information in a short period of time, and that's what we're doing every day. So we hope that you found this helpful. We know the stroke scale is exceptionally difficult, and don't be afraid to ask questions. We're around. We're available by phone. If something happens and you need more explanation, or you don't understand, or you just want to have a dialogue about the patient, that's what we're here for. So
Thank you very much.
Thanks, guys.